Today we have with us Susan Garpiel. She is the Director of Perinatal Clinical Practice at Trinity Health and has been there since October of 2013. And she is the co-lead for Unified Clinical Operations System-Wide Perinatal Patient Safety Initiative. In this position, she's responsible for leading perinatal safety and quality efforts to transform care across the continuum in 40 birthing hospitals in 18 states. That helps ensure that they achieve optimal population health outcomes consistent with the triple aim. Prior to joining Trinity Health, she had more than 30 years' experience as a clinical nurse specialist responsible for advancing evidence-based clinical and nursing practice and perinatal safety initiatives. She held multiple clinical staff roles across the perinatal continuum. She has an international board certification as a lactation consultant and served in that role for 20 years. And she also served as academic and clinical nursing faculty at UCLA, Saginaw Valley State University, Delta College, and as adjunct faculty at Michigan State University. She's been the primary investigator for 4 perinatal research studies. Her articles and research have been presented at A1, both nationally and at state conferences. And she's published in the Journal of Obstetrics, Gynecology, and Neonatal Nursing, Maternal and Child Nursing, and the Journal of Perinatology. She's received multiple Nursing Excellence Awards, and Trinity Health has implemented the OB Hemorrhage AIM Safety Bundle and is currently implementing the Safely Reducing C-Section and OB Hypertension Bundles and the Maternal Early Warning Supplemental Bundle. Welcome, Susan.
Thank you very much for inviting me today. And I wish I was actually down there live in Florida because here in Michigan, it's 5 degrees. So really appreciate all of you joining and hearing what we have to share and what we've done at Trinity Health. So we call this Overcoming the Resistance to Change, Be the Change Leader, because what we have found in implementing across our system, the biggest area is trying to get the engagement of all the clinicians to move the change forward. Because if we're not able to do that and overcome that resistance, then we're not going to be successful. And so I started this slide with having like a superhuman being person here. It looks like representation, being a person of steel, because sometimes that's what it takes when you're a change leader is you have to, go into your meetings and talk to your clinicians with your suit of armor on, and because you never know what's going to happen. So as we look through the next piece, I do have on the next slide a picture of myself as well as my physician co-lead, Dr. Jerry Girardi, who operates out of Ohio. I want to share a little bit about what we're going to do today. So the purpose of this conversation is to really talk about transformational change. And what I'm going to do is I'm going to use the change tools that I'm going to be discussing with you today in terms of how we've applied them, particularly with the AIM bundle, Safely Reducing the C-Section, and how you can use these tools to overcome resistance to transformational change, particularly when we're looking at reducing cesarean births. So we begin, just want to tell you a little bit about what this is and what it's not. So we have a disclaimer on slide 4. So what this is not any magical toolkit that we're going to share with you. It's not something you can wave the wand and all of a sudden your resistance is going to melt. It's not really a discussion about brainwashing. And I'm not going to be going into detail about what the CMQCC toolkit to support vaginal birth and reduce cesarean births. Those are a lot of strategies that you can use as you undertake the initiative. But basically what we're going to focus on today is strategic planning, strategic thinking, to help all of your clinicians navigate the change so that as you undertake these initiatives that you can be successful. So it's really taking these leadership tools and transforming behaviors throughout your system towards your goals. And so I did share then in the next slide what we are. This is Trinity Health. We're the second largest Catholic health system. We have 40 birth ministries, and we call our hospitals ministries. And it's in 18 states. And so you can see we actually do have one that's down in Florida. In 2016, we had almost 70,000 births. So we have a good, nice little percent of the United States population. And so there's quite a bit of diversity and variability all across regions and the system. And on the next slide, I have a slide on PPSI project history. I don't want to go into detail on this. Just want to share with you that Dr. Girardi and I, we've been doing this for a while. He actually started before I did. We've done this across 25 hospitals, and we merged and added additional 10 hospitals, and so now we're up to 40. And these are a number of initiatives that we've implemented to reduce risk, to validate competency in practice, and to reduce maternal and perinatal morbidity and mortality. So we've kind of been around the block a little bit on this and have learned a little bit along the way. And so when we look at slide 7, we want to really clarify what we're talking about in terms of types of change. Because there's really 3 basic levels. You've got your developmental level, which is really the simplest. So you're trying to improve something on what you're currently doing. So for example, if you want to teach a new technique in labor support, maybe you want to start using the peanut ball. That's a developmental change, and that's pretty easy to do that. And then you get to transitional change, and that's like replacing what you have with something completely new. But what you're going to put in place is not a radical change in the workflows, and it's not going to require a cultural or behavioral change to get to that new state. So an example I can use that we did in our systems, we looked at how many of our hospitals were actually using Bishop score and parity to determine the method of cervical ripening induction. And we found that there, many of our hospitals were, some were not. So we felt that this was transitional because we're like, okay, well, in the old way, we just started the induction. This way, we're actually using Bishop score and that to drive that for effective induction. But the last one is transformational change. And that's the most difficult. And that's where your future state is so radically different from what you're doing now that people and culture must change to be able to implement it successfully. And so it requires a whole new mindset and behaviors, new workflows as you're trying to navigate the change. Well, I can tell you, based upon all the things I've showed you that we've done in the past, that this aim, safely reducing the first C-section bundle, is definitely a transformational change. And if you look at some of the websites, look at Childbirth Connection, CMQCC, they're all calling it transforming maternity care because that's what we're doing. We are taking how we normally provide a maternity care and turning it upside down because there's a number of processes and behaviors that need to change for us to move to that state. So I like these cartoons because it really tells you what happens when in responses during transformational change. I like the one specifically with Dilbert. So our differentiating value-added strategy is transformational change. How was that? Does anyone feel different? Well, my urge to hurl has increased a little bit. And, well, that's what change feels like. And isn't that what happens when you announce to your department or you announce at a meeting that there's going to be a major change? Everyone starts getting anxious. Fear is a primary response to that. What's going to happen? What does this mean for me? What's going to happen to the organization? What's going to happen to our patients? And so with that fear, a lot of responses can occur, and that can drive a major part of your resistance. And so the key strategy is you want to really change the fear. You need to be able to respond to why is this fearful and what do we need to do? So in 2012, Tipton actually published the 9 stages of transformational change. And I'm not going to go into detail about what each one are, because in the supplemental materials, I actually put a definition for each of those stages. But I want to refer you to the left side, where we have status quo, denial, righteous resistance, and pleading and despair. Those first 5 steps, you could actually superimpose that upon the stages of grief. And so that's what it is. When we change, particularly something that's transformational, we are grieving what the old is. And you have to go through those. You have to recognize everyone has to go through the old and to be able to get to the new. And you'll see on the slide that in between those first 5 stages, up until actually the 6th stage of tolerance, that there is an area that says retreating. Because any of your clinicians or colleagues who are in any of these first 5 phases may likely retreat back to a previous phase, depending upon where they are in the process. And so as you get them through that grieving phase and move up beyond tolerance, then you can see that they're more towards accepting, agreeing, and actually you will end up with advocates, those who will actually go out and sell the change that you want to create. And you all know who they are. You've been working with your clinicians and your organizations. You know who the early adopters are. You know who are the ones who are probably going to be the most vocal when you bring up the change. And then you also recognize who are the ones who have the most power in terms of what they say really counts because of the trust in the organization. So as we talk about this and you start thinking about the change, think about where your clinicians fall in terms of the stages of transformational change. Who are they? Because this is how you're going to help get those who are in the agreement advocacy area and help mobilize their efforts to work with the other clinicians on the left side of the spectrum. So now let's talk about our next objectives. I'm going to take these two leadership tools that reduce resistance to change and apply them to how that you can improve clinician engagement and commitment to that AIM bundle. And so first, I'm going to share with you then a little bit about our journey and why we come to value these leadership tools so important to this major change. So at Trinity Health, we are in an AIM system in which we've adopted this bundle. And we actually have a number of processes already in place. We have a standardized cervical ripening and induction augmentation oxytocin guideline. We have a standardized guideline for fetal monitoring. And so we thought, well, okay, we already have these things in place. And so we just need to pull together some work groups to look at these processes that we have in our standardized order set and how can we leverage those then to take on the strategies for the bundle. And so we create a large group in these 4 work groups. And we emphasized from the very beginning that our goal here was not to prevent cesareans at all costs. We're primarily focusing on supporting intended vaginal births. We're looking at low-risk women. But yet we have to understand what's normal, because that's fundamental in terms of how we're going to look at a judicious use of interventions. And so we started this process and convened these groups. And then on slide 13, we looked at the barriers to support intended vaginal births. And this came directly out of the FPQC toolkit. And we thought, well, the first 5 really resonated with us. And so I thought, well, let's look at those and in more detail and to determine how that is in our system and then how we can develop strategies around that. And so in slide 14, then, with our meetings, we decided we had our first experiment. And that's what we call things when we start something new in terms of the lean technology. So one of our work groups, that's the fetal uterine surveillance work group, took our guideline that we had and said, wow, all the components are in here that's necessary to support the bundle except 2 things. The first thing is we don't have anything in there about intermittent auscultation. And so we probably should add that component in there. And as we were working through this, we said, well, in order for this to be effective, we need to make sure and delineate what are some examples of high-risk conditions or indications for considering continuous electronic fetal monitoring. And so we looked at some of the model policies, reached out to the CMQCC leaders and said, what have you found to be effective? And what are criteria that you're using? We took that, we vetted it through our groups. We had nurses, we had physicians on our groups, and looked at this criteria, and we decided, okay, this is great criteria. And then we found, well, we do have the ACOG management of tracings, but we didn't have the detail for the management of the Category 2 tracings. And we knew that to be a problem because we were seeing some SREs in which that are serious reportable events in which patients were having bad outcomes, and category management of Category 2 was an issue. So when we looked at this, we thought, oh, this is just a transitional change because all we have to do is just put this criteria in there, put this algorithm, send it back to our big group, and call it good. Because we're just replacing what's existing, and the new state is we're going to just add intermittent auscultation. And we really didn't anticipate any radical change in the workflows or cultural change because RNs are trained in that. All of our hospitals have educators that do intermittent auscultation training as part of their fetal monitoring training. And we have the equipment to do that, so shouldn't be a big deal. So we took it back to our big committee, and lo and behold, this is what we met. And I will tell you, this is from clinicians who are our leaders. They are the ones who are in the advocacy area of transformational change. So it was quite a surprise to hear that there was resistance among our key leaders. And so as we were looking at this, we said, okay, well, what is it about this? And they said, well, this is not what we do. We don't do intermittent auscultation. No. And we said, well, wait a minute. Let's look at the ACOG literature and, talk about the safety in comparing intermittent auscultation and continuous fetal monitoring. We said, oh, yeah, we know the literature, but we still want the option to do continuous fetal monitoring for low-risk women. And we said, well, why would you be concerned? He said, well, we think we're going to miss something with intermittent monitoring, even though they're low risk. But the bottom line, when we kept digging deeper into why we're getting resistance from our key leaders, that what we heard is that the physicians at this team said, you know what, we know how to use auscultation in our office, but we've never had any training or experience using intermittent auscultation in labor. And we're not comfortable having that visual tracing. So basically, this was our first failure because we forgot the rules of engagement. We really should have had more engagement from hospitals in which didn't have nurse midwives and all of that, who had not used this as a practice. And so this took us back to the drawing board. We said, okay, from those rules of engagement, we got to learn some lessons. And so we thought, well, okay, let's find out how many of our hospitals are using intermittent auscultation, because that shouldn't be a big deal for them, but it's the other ones that are not. And when we sent out that survey discussed on slide 16, we found that only 8% of our hospitals almost always use intermittent auscultation in low-risk women. And those were predominantly in places that had certified nurse midwives during the birth. And so we really decided that, okay, so if we're going to move further with this, in order to engage our physician clinicians, we're going to need some education regarding that intermittent auscultation. But we had to be realistic, because we kept hearing that we thought in some cases there may not be staffing, there may be issues of equipment. We knew that this is not going to be adopted universally, and so we actually have a backup plan now. So we are exploring wireless beltless fetal monitoring, as a standard, and we've written a grant for that. So don't have any information about that, so more to come. But you can see how we had to go back and engage our physicians and understand why it is that there is resistance. So on slide 17, I just want to call this to you because any of you who have implemented change recognize that sometimes change is not just putting another checklist that in your documentation, or changing the order set, or just education, because we know education alone only does so much, but it doesn't change entire practice. And so if you look on the left, this is the change pyramid that it's not a Trinity Health thing, but it's universally accepted, in which identifies the different levels of things that need to occur and to align as you're making a shift in a change in your organization. I want you to look at the bottom. What is fundamental to all of this is the culture for why we do it. And if we don't establish that in the very beginning with your clinicians and colleagues, why we're doing that, and have them share in the vision, that you may create these great checklists, these great policies, protocols, but they're not going to be successful unless you can go to the heart of it and hit the culture. So on slide 18, I want to first talk about then these two tools. We're going to talk about the DVF greater than R, and that's an actual formula, and I'll talk more about that in the next slide. But this tool actually builds the case for change to overcome the resistance. It's designed for that. It's very systematic. So I believe from all the work that we've used with this, it's basically a formula for success in getting that culture to move. And on the right is the path to commitment, and that's the other change leadership tool. And we found using this then that helps change leaders understand that people side, because you know where everybody is in terms of their commitment to do this. And we've used this tool when we started this process for safely reducing C-section and getting our vision and everything together. We went through this in every single meeting to find out where our key leaders were along this pathway. Because if you don't have a critical mass following through that pathway, then you're not going to be successful. So I'm going to first start talking on slide 19 about building that case for change. That's that formula for DVF greater than R. And what that does is it takes the dissatisfaction with the current state or data, multiplied times the clear vision for what you're going to do, times the first steps to overcome the resistance that you're going to hear. And that may sound complicated initially, because I know the first time I learned this tool, I thought, well, how does that work? So I'm going to take you through how we did this at our organization relative to this initiative. So when we look at the formula on slide 20 is resistance. And so I have a lot of information on there for all of you, but I want to basically say, I think we all know what resistance is. We recognize that. And I use a lot of pictures of babies because we can all identify in our system that we're doing this all for the benefit of the moms and babies. So you're going to see a lot of baby faces starting from here. So we know resistance. We've seen that. We've heard that in anything that you've done. And we know that it's because that it's part of that grieving. We know that if they believe they're going to lose something, that's going to create this problem. They may not trust in whoever's initiating a change, or they may feel they don't have enough knowledge. Because all of us, wherever we are in terms of our practices, we are at various different levels. And when you gain a certain level, when you have to go back and do something new, that takes you back to the beginning. So that can cause some uncertainty. So anyway, going on to slide 21, well, I want to emphasize first on slide 20 in the red, that by far the most effective method of dealing with this is that engagement, engaging your important stakeholders to shape all those elements on the left side of the question, that D, V, and F. So I want to take you to slide 21. I originally was going to try to pull this, but we've had some technical difficulties in the call. So I want you to think about this. If you went to your department meeting today and said, okay, we are considering no longer doing elective inductions less than 41 weeks. Now, I will tell you, when I initially gave this example and sent my slides in, I did not have the crystal ball to interpret what happened at the Society for Maternal Fetal Medicine. So I know a number of you are going, oh my gosh, this is like all in flux now. We got all this stuff going on. So I'm not going to get into that today because there's a lot of discussion that we could have that could take up the time. But I'm just using this as an example. What would happen if you went to your department and posed a change? How would they respond? Well, we did that in the very beginning with our group. And exactly what we wrote down here in quotes is exactly what they said. This is the face of resistance. This is what we hear no matter what initiative. Oh, this is our routine. This is the way we've always done it. Yep, this is the way I learned it. Doesn't matter if it was 20 years ago, but this is the way I learned it. We're more likely to be sued by not doing a C-section. Or, you're taking away our autonomy. Now you're pushing it. We couldn't do any elective deliveries less than 39 weeks, and now you're pushing the number. So, or it doesn't work with our office time. And then also you'll hear, because we've heard this across many places, that this is what the patients want, because patients come in, they're tired of being pregnant, and we need to do this to help improve our patient satisfaction scores. So I'm hoping this is resonating with some of you, because this is what we found across our system. And so if you know that these are the things that you're going to hear, because you've heard these before, this is an opportunity where you can do a little deeper dive behind here, because we need to get beyond routine, the way we learned it and all of that. We need to dig to the root for the resistance and what needs to happen. So let's go on to the other side of the equation on slide 22. So we need to start with the dissatisfaction, the current state or data. So you need to find out, get all your stakeholders together, the ones that are going to be the most resistant, the ones who are going to be your advocates, and bring them all together and say, okay, what about our status quo? Can we stay the way that we are? Okay, maybe we can't stay the way we are because, we aren't practicing the evidence. Maybe we can't stay the way we are because our C-section rates are high. So we need to kind of work through the group with that and give them the information for why we can't stay as we are. And basically that involves giving data. And so what we did on slide 23 is we looked at what are the most common questions that people are going to ask despite any kind of change that you're going to use, because this is how you're going to gather the data to establish the case for change. And so these three questions are questions that are asked in every transformational change. First of all, what's in it for me, the WIFM, both the positives and negatives. Second, is it good for my hospital? Is it good for my team? Is it good for my patients? And then also, finally, do we have what it takes to be successful? Do we have the resources? Do we have the equipment, technology, and do we have the will, the discipline? Do we have the commitment to do that? Those are all questions that, when you're in that data dissatisfaction change, that need to be explored, because using that information can help begin to build that case for change and overcome resistance, because you'll have the answers to the questions that will be raised. And so I just want to share just a few things that we use that may help you. On slide 24, we looked at what Elliott had done with CMQCC for their state of California, and they looked at the Healthy People 2020 target of 23.9% or less. And they shared that and shared the variability. So we thought, okay, we'll start with that. And so as on the right, you can see we actually have a scorecard. We have all of our hospitals that we listed during a particular period of time and showed what their NTSC rates were. We looked at how many of them were above that 23.9 and found that we almost had 70% were above the national target. So we felt that, okay, we do have some opportunities in a number of our hospitals. And then on slide 25, I'm not going to go into detail. I think you had a previous call about this, but we also did bring in the fact that these rates are going to be transparent and they're going to be out there in Yelp. And so we want to make sure that we're aware that our rates are going to be out there and going to be scrutinized by payers and by our potential patients. And then on the next slide, we also brought up the professional practice guidelines and opinions. What is out there? What is the evidence saying? What do we need to do to make sure that we have standardized practices? We're practicing to the evidence. Because if there's any problems with our care, we're always brought back to the standards. And this is the model of what we are. We want to practice based upon that. And then on slide 27, we said, okay, well, let's look at women. What do women really want? And we brought up that there are been some national studies from Listening to Mothers 3, and which found that most women, want to have a birth process that's not interfered with. They want to know if there's anything that is an intervention. They want the risk benefits alternatives. And we actually brought our data from the HCAHPS data on women's perceptions and brought it to our national teams and said, this is what our women are saying. So we leverage that information to show that women do want to have a say. They want to have shared decision making, and they don't want routine procedures. So a couple of things we did on slide 28 is we actually had patients come to our calls, on our work group calls, our national calls, and shared their birth experience so that they could share what they wanted, what did happen, and what didn't happen, so that we could, as a people-centered organization, keep that at the center. And the same thing with slide 29. Sometimes we would get into conversations in which we had some clinicians leaning more to the what's in it for me rather than to our national goal, which is being people-centered. And so anytime it came to a critical decision, particularly when it came to an elective intervention, we said, okay, you put yourself in the place of the woman. And if you had a choice for this, because it's an elective intervention, knowing the potential risk, what would you choose? And then think about it then, moving forward with your patients. So as you start proceeding with these interventions, is there shared decision making? Are you discussing the risk, benefits, and alternatives with that? And so it really kind of brought this all back down to the center in terms of this is all for our patients. So just to summarize on the next slide, we took all the data from here to establish the case for change. We showed them that our birth experience scores are not where they need to be as well. And so we said, okay, so this is what we know. What else do you need to know in order to convince you that we are not satisfied with our current state? And so we worked through that in terms of looking at other data and audits. So now I'm going to move to vision. And so vision is the V part of that formula on the left. And that's where you have to have a clear vision, because once you say, okay, we're going to do this, and we don't have a plan together, this is going to result in a lot of emotions. You're going to have anger, people are going to be depressed, frustrated, because it's, for some reason, we need to change, but we don't know how to get there. And so if you could sit down with the group that's driving this and say, okay, all right, what do we want our future state to look like? Let's be very clear, and we can use those as foundational principles. And so I want to share with you then on slide 32 what our groups came up with and that we shared on our national calls to share with all the clinicians. And we worked through all of these. There was some changes, but this is the final one we shared. And we all committed that this is the vision that we want as we look at this particular initiative. We want to improve birth experience. We want to improve birth outcomes. We want to be evidence-based, and we want to improve our culture and that recognize there is a value to vaginal birth because there are risks related to C-sections. And so I'm going to go then to the next steps, or what we call the first steps on slide 33. So as you work through your vision, then you need to start thinking about something clear. It's great to have a vision, but you need to have something clearly articulated. What are we going to do? What is our first steps that we need to accomplish this? Otherwise, these are great ideas, but we're never going to get there. And so all of these stakeholders you have need to be taken through this and where you identify first steps. And for those who are interested, we actually have at the end of the supplemental materials some slides that talk about the first steps that we came up with from our individual work groups that we've taken to the system level. So if you go to the next slide on first steps, what we found out from that first experience, that epic failure with the fetal monitoring and intermittent auscultation, we decided, you know what, we need more data. We need to know what are the practices happening in our organization. So we created an assessment tool and sent it out that looked at practices. We made no assumptions at all and try to find out who were the ones who are always doing these. So these were our high performers, those who have not even reached to that level, who are going to need more support. And then we took that CMQCC toolkit and looked at the top 10 drivers there on the right for the first steps, and then started working towards aligning our data of where we needed help with what those action steps are to create our first steps. And so we prioritized those in terms of what we felt had the most impact and the easiest that we could get. I mean, the challenge that we have is for a system-wide electronic health record is getting it timely in there. So that would certainly not be a first step. So now I'm going to take you to the pathway to commitment. And I'm just doing a little time check, see where we are. Okay, good. So the pathway to commitment is that model in which you look at each individual or your group's journey to go from the awareness understanding phase to commitment. So you want to keep them on the green path. And anyone who falls off the path in resistance or compliance, that's where we need to use our strategies and to work with them to get them back on the path. And so a change leader's role then is to understand who are the key stakeholders are, where they are on this path, and then particularly the key ones, you need to get them back on the path to help you with, overcoming your resistance and having successful change. So the first part of the path on 36 is awareness and understanding. And this is going to look familiar because in awareness and understanding, you need to have a critical mass to understand your case for change. They need to know the reasons, why you're doing it, what you're doing, and so that any questions that come up like, oh, what are we doing? Why are we doing this? That they need to have that information. So all those things that you did back in the data part and gathering all the information, you'll have all of that for them. And if you do a great job in terms of getting that together, you'll have everyone at that awareness, understanding level that can really begin you on that course. And so then when we go to slide 37 is the belief phase. And so that's where in that phase, your key stakeholders need to believe at least one thing, either that this change is good, the change is good for me, or we can change it successfully. Because if they don't have one of those, they're going to stall. They're going to go into compliance or resistance. And we'll talk about what those mean shortly. So what we did is we had just finished implementing a safe second stage of labor care bundle called the 4 Ps. And we had done the system-wide and had significant improvements. And on the next slide, you'll find out that we are sharing here, because we just got this published and it's going to be presented at ACOG in April, that we significantly reduced the NTSV rate in 4 months by a really proactive approach to standardizing practices in the second stage without, changing anything in terms of maternal morbidity or delivery outcomes, and actually improve the term newborn unexpected complication rate. So we had very much success. We were kind of riding on that going, wow, if we did this, we can do this, which was really hard. We can do anything. So we knew that we had what it takes. Now we need to kind of work with the individuals. So on slide 40, then, I want to take you then when you have individuals that fall off the path. So you're back to resistance. We all recognize that. And that's basically someone who thinks that this is not a good idea, or it's not going to work, or they're not ready to commit. I will tell you the thing about those who are actively in resistance, they have energy behind them. You can actually use that energy that they have to mobilize them. If there's someone that's not on your committee that are swaying the group because they have areas of resistance, invite them to the committee, get their ideas, find out why that is happening, because a key stakeholder needs to go back on that pathway, but they'll have the energy behind it because they're passionate about that. And then on slide 41, you get to compliance. And you can see that is way off the path. You think it wouldn't be, but it's way off the path because these are the individuals that go along, but really their heart's not in it. And they have little energy or effort. And I will tell you, we poll everybody on everything. I'm really into polls because what we found is that a lot of times you'll not hear anything. When you talk about something, you think, oh, okay, nobody asked questions. Okay, we think that they're okay. But then you find out afterwards, nope, they were in conformity, or they were conforming. They were in that compliance stage. And the thing about that is they don't have any energy to change it because they are waiting in the wings. And so if the change is swaying towards the people who are resistant, they'll go with them, but they're not going to put anything behind it. They're just kind of going along, walking the line. So they're ones that are probably the most difficult that you have to work with. And then I want to talk about the last phase, and that is the commitment. If you keep them and get them back on the path, that is the area where you have a critical mass to take the necessary actions to make a change. This is where you have the critical mass of people saying, yeah, let's just do this, because you may still have a few naysayers, but we can move them along on that pathway. So on slide 43, I want to summarize what you can do to move them towards commitment when you have people falling off the path. I think the biggest one is that engaging the stakeholders through the entire process. And that's where, when you use these tools, get them involved to create that case for change. Get them involved, in terms of saying, what data do we need, and looking at the data and coming up with ideas. And once you do that, you're going to have great engagement and you're going to be more successful. And then also that DVF greater than R, we use that for every strategy. We no longer say, oh, okay, well, this change is going to be simple. It's not going to be a problem. Everything, we want to make sure that you never know what's behind some of the resistance. So we use that for every strategy. And then recognize that where your key stakeholders and major decision makers are in that transformational change process. Look at that slide from Tipton and identify the behaviors, because you're going to need to help them along to help you through the process. It takes a village sometimes with this. And then moving from compliance to belief, because I told you that was the most difficult. You have to shift the compliance to that belief piece. That's where you use your audits. You're looking at your data and your data sources and monitor the progress of how you're doing. What you'll find is that you'll have early adopters who are going to really want to change, and leverage their wins and their successes and ask them to present their learning and successes on the calls. And that will show that, okay, you can be successful, and maybe they can answer some questions to solve a problem that no one's been able to answer. And then the last thing is provide positive feedback. Your early adopters are taking a risk. They're truly, experimenting with some of these things. And so you want their feedback, and you want to praise them openly about what they've done and what everyone's learned, and celebrate the success. So on slide 44, I want to kind of get close to wrapping up the discussion here. Changing culture starts with that vision and action. And this, we always start our calls with a reflection. And this is a reflection that we've used in all of our work groups as we've done this. And this is kind of a vision that we have that actually we'll know when we get there when this occurs. So imagine if our culture told us that birth was one of the greatest things a woman might ever do. Imagine if the stories and images we were exposed to taught us that labor is an incredible and transformational experience, a rite of passage into motherhood, that it's normal. So on slide 45, just have some final words of advice and to all of you. So take these tools, work with your key stakeholders, and come up with some really good steps that are going to give you initial success. Once you achieve those baby steps, initial success, you'll be able to build on that success. So you want to be that change winner, because that will bring the trust as you get into some of those more difficult states. And you definitely don't want to be on the other side, the change whiner. And anyone that's a change whiner, we want to get them engaged to help them move you towards success.